பிஎஸ்சிக்கு மெயில் பண்ணிருக்காங்களா? அந்த மேம் ஹாஃப் அன் ஹவர் கழிச்சு கூப்பிட சொன்னாங்க. அரை மணி நேரம் கழிச்சு கூப்பிட சொன்னாங்க. இதெல்லாம் உடைச்சிட்டாங்க.
No video later. Good morning. A very good morning to all of you from MSSI Kolkata. This is Anirban Banerjee, Honorary Joint Secretary of MSSI Kolkata. And today we have assembled here at INK, Institute of Neurosciences, Kolkata, for the webinar, Managing MS with Neuro Rehab. And we'll have our young member, Payal, to start off the proceedings at the earliest. She is ready and we are good to go now. Over to you, Payal. Thank you.
A very good morning to everyone. Welcome to today's seminar on managing multiple sclerosis with neuro rehabilitation, a joint initiative by Multiple Sclerosis Society of India, Kolkata Chapter, and Indian Institute of Neurosciences, Kolkata. My name is Payal Thakapadas, and I'm delighted to have you all join us here. Neurorehabilitation plays a crucial role in the management of multiple sclerosis, helping individuals improve their physical functioning, enhance the quality of life, and maintain their independence. It includes a range of therapies and interventions designed to address the unique challenges faced by those suffering from multiple sclerosis. Our esteemed speaker today, Dr. Suparno Gangopadhyay, and his wonderful team, who will be sharing valuable insights on this important topic, is here with us. To formally commence the session, I welcome Mr. Anirban Banerjee, Honorary Joint Secretary of MSSI Kolkata Chapter. Please, sir. Thank you for joining us, and we look forward to this informative and engaging seminar.
Good morning, all. It's wonderful to have all of you over. Fine, thank you. So, see, we have assembled here, and today I was just talking to Dr. Gangopadhyay. It's a day of abbreviations, okay? So it's very hot and humid here, so we don't want to talk too much and exhaust ourselves because we are all fighting MS, right? So we are here at INK. INK is Institute of Neurosciences, Kolkata. And I and my team, we are here, quite a few of us, we are from MSSI, Kolkata Chapter. MSSI is Multiple Sclerosis Society of India. And of course, the person or the issue in contention and is MS, multiple sclerosis. So yeah, so it's all abbreviations. And today we are meeting here with Dr. Suparno Gangopadhyay and his fantastic team, as Payal just now said. So we are going to talk about managing MS with neuro rehab. Rehab is rehabilitation. So another abbreviation, rehab. Yeah. So that's the purpose, because we are celebrating World MS Day. For last 1 month, we have 9 chapters in the country, in different cities, and Kolkata is one of them. And we have been having so many fantastic webinars and meetings and seminars. So here the issue is that once someone is diagnosed finally with MS, maybe late, and is under some kind of medication, whether oral or injectables, how do we give a better life, better quality of life to all our friends who are fighting MS? In that, this multifaceted approach of neuro rehabilitation will play a very, very big role. And that is the reason why we have the neuro rehab team of INK along with Dr. Suparno Gangopadhyay to speak to us, to brief us, to take our questions, and obviously make a better tomorrow for all of us. So without further delay, I would like to hand over the stage to Dr. Suparno Gangopadhyay. Most welcome, sir.
Good morning, friends. First of all, I'll like to convey my heartfelt gratitude to Anirban and the MSSI Kolkata chapter for giving us this opportunity to be a part of this webinar. I'm sure every one of you have heard a zillion number of times about what is MS, pathology, physiology, symptoms, science and medicines, drugs and everything. But here I am, here the team of INK Neuro Rehabilitation is not here to discuss anything about the theoretical approach. What we will try to do is to help you to learn how to live with MS and manage MS through neuro rehabilitation. Now, what is neuro rehabilitation? Rather than going into the theoretical part of it, let me just explain it through an example. Just for example, friends like you who have been diagnosed with MS have a lot of symptoms. Example, someone of you might have difficulty in walking, difficulty with your balance, with your gait, with your coordination. So here comes the role of a physiotherapist. Now, once the physical part improves, then you have to translate that into your functional outcomes. There comes the role of an occupational therapist. The same goes for speech, language pathologists, nursing staff who are a pillar of this department. Then you have the rehabilitation psychologists, social worker, your orthotist and a prosthetist, and this whole team is manned by doctors like us who are the rehabilitation medicine consultants. So in a nutshell, at the end of the day, we work with you to improve your quality of life. We actually are here not to fix your problems, but we are here to help you manage MS through this department and its expert professionals. So what we will, rather than taking much of your time, in the next half an hour to 40 minutes, we will run you through the journey of INK Neuro Rehabilitation, where the therapists will explain to you how you can manage your symptoms with our help. At the end, what I'll try to do is summarize what have been discussed and then wrap it up with a question and answer session, so that if you have any doubts, we can always clarify that. So I'll pass on the baton to our speech and language pathologist, Miss Sneha, and she will talk on the problems that you face with your speech, language, or even swallowing. So, Sneha, please come. Thank you.
Thank you, sir. Good morning, everyone. Today I will talk to you about the speech, language, and swallowing difficulties that an individual with multiple sclerosis can face. And I'll also take you through the management for these problems. So some of the most common complaints that we hear in the OPD are things like my voice has changed. I have to repeat myself because people don't understand what I'm saying. The clarity of my speech has reduced. People can't, understand when I'm telling them something. So if you are familiar with these complaints and you experience these things yourself, your first step would be to visit a speech language pathologist. So when you come to us, first we will do a comprehensive evaluation and find out where the impairment lies. And after that, we will work with you to form a patient-specific treatment plan and set the goals for therapy. So with regard to speech, if your speech is impaired, it can have a negative impact on your communication skills as well as your quality of life. So this impairment in speech is what we call dysarthria, and it affects all these subsystems, your respiration, articulation, voice, resonance, prosody. And let's look at each of these subsystems and what are the complaints you might have with regard to these subsystems. So the first is respiration. Do you sometimes feel out of breath while speaking? Okay, so your complaint might be it's like too much effort for me to speak, or sometimes when I'm speaking, my voice breaks and I feel out of breath. So if this is your complaint, that means there's an impairment in this subsystem. So a way to confirm this is if you can take a deep breath and say ah for as long as you can, check the number of seconds that you can go. So if 10 seconds or less than 10 is the maximum you can go, it can mean that you have inadequate breath support for speech. How would you manage this? Many times when I tell patients to take a deep breath and speak, what I see is they do a lot of clavicular breathing, or there's a lot of movement in the shoulders or chest. So, but abdominal breathing is what is most optimum for speech. So if you can place a hand on your chest and one on your abdomen and take a deep breath. So when you take a deep breath, there should be minimal movement in your chest and shoulder area. And when you inhale, your stomach should go out. And when you exhale, stomach goes in. So that is the optimum breathing method for speech. Secondly, articulation. So a lot of the complaints that we get is my speech sounds slurred and my speech clarity has reduced. So when we are speaking, our articulators, as in our lips and tongue and then jaw also, they make a lot of quick and precise movements. When this movement slows down, when there's a weakness in your speech musculature, what happens is the precision of these movements reduce, and that is what causes your slurring speech. What can we do for slurred speech? Oromotor exercises are definitely there. These are exercises for your tongue and your lips, and basically your oral muscles. So there are exercises which we can give you to stimulate these muscles, but oromotor exercises itself will not help you bring clarity to your speech.
बस न बीच का ये हॉल नहीं और न ये दोनों में से एक करेगी ना क्या हाँ ठीक है एक दिन करती ना छोड़िए नहीं
Ma'am, kindly request
Hello.
all of them to put themselves on mute.
Please mute yourselves, friends. Someone is speaking on MS issues. Please mute yourselves. Thank you.
So as I was saying, oromotor exercises will definitely help stimulating the muscles, but that alone will not bring speech clarity. So we will advise exaggerated articulation and other such compensatory strategies to improve your speech eligibility. And this is done at multiple levels. So you need the help of your speech language pathologist to help you go through these levels using the compensatory strategies that we teach and maintain it even outside the clinic. For example, over here, I have a list of multisyllabic words. So if I'm going to read them out just like that, it will be anarchist, abbreviate, abdicate. When I'm going to tell you to read it with exaggerated articulation and an open mouth approach, it will be more like anarchist, abbreviate, abdicate. So this is when you're breaking down the words and at the same time applying more pressure to your articulators. This helps improve your intelligibility. And as I said, this is done in multiple levels. This is just the first level. You need the help of your SLP to use these strategies, not only while reading multisyllabic words. You have to again progress to phrases, sentences, passages, and even use these same strategies during conversation in and outside the clinic. So you cannot improve speech without practicing speech. So this is a whole rationale behind this method. Oromotor exercises, only oromotor exercises will not help you. You need compensatory strategies as well. Next, with relation to voice, many patients have a complaint that my voice sounds very weak or breathy. Some patients might even say that their voice sounds very hoarse. So based on the quality of your voice and how it has changed from before, based on this and evaluation that we do, we can suggest vocal fold exercises and which will help you improve the quality of voice. Some patients, again, they have the complaint that my voice is not as loud as it used to be. So loudness exercises, especially with visual feedback, is very promising and a lot of patients benefit from it. These apps are freely available. For example, Decibel Meter is a freely available app on your iOS and your Android devices. So if you open this app, you will see a graph. So this red graph, it helps you track the loudness. So when the loudness increases, the peaks go up. And when there is a reduced loudness, the peaks go down. So with the help of your speech language pathologist, you can track your loudness levels and then find your optimum loudness level and maintain it even without the app in front of you. So even in the absence of this visual feedback, you have to maintain the same level of loudness. And then the generalization outside the clinic is also important. Then some patients come with the complaint that my speech is not as fast as it used to be. I used to be able to speak faster. It has comparatively slowed down now. So for them, usually I would say this slow rate of speech that they're experiencing can actually contribute towards their speech intelligibility. And you can actually use it to your advantage. So when you're speaking at a slower rate, along with the compensatory strategies for articulation, the person in front of you has better chances of understanding you and your speech intelligibility improves. But for patients who want some sort of change in the rate of speech, we use a metronome. A metronome produces an audible click at uniform intervals and it can be set by the user. So you, along with your speech language pathologist, can find out the interval that is best suited for you, the beats per minute that is best suited for you to achieve an optimum rate of speech. So for each click, you say a word.
Yes, now we are able to see the screen.
Thank you so much.
Okay. So multiple sclerosis, that was the speech part. So now let us look at language. Some of the complaints with respect to language are word finding difficulty, or what we call anomia. And there's a overlap of language and cognitive deficits as well. So a person might say like, if you show an object to a person, and this is usually in the advanced stages of the disease. So when you show an object and you ask them what it is, they have a tough time recollecting
कि
the
तूने
object.
सबसे पहले क्या किया था? मेरे हिसाब से तो सबसे पहले पापा वाले रूम में गई थी, उसके बाद तू भैया के। उसके बाद वो वहाँ पे
I request all the participants to please mute on your end so that everyone else can hear. Okay, so the management for this, so word finding difficulty. How would you cue a patient? So for example, this is a picture that you show to the patient and you ask them, what is this? If they are unable to say it, the first thing is not give the answer right away. The first thing would be to describe the object. So you say things like, this is used to clean your teeth. You use it in the morning. It's usually kept in the washroom. What is it? After that also, if they have a tough time recollecting the name, then you can give them a cue as a phonemic cue, which is, it starts with the letter T. You just start saying it for them, like the first syllable, and help them complete it. So this is how you should cue them. You should not directly give the answer to them in the first stage. Other tasks that you can do for language are semantic fluency tasks. So name as many animals as you can in 1 minute. Phonemic fluency tasks, say as many words as you can that start with the letter P in 1 minute. You can switch it according to your choice, and whenever you're practicing with the patient, you can switch the tasks. Now, MS and swallowing. So dysphagia refers to any disturbance in your swallowing, and the symptoms commonly seen in an MS patient are choking on food or drink, coughing after swallow, drooling, excessive drooling, inadequate chewing, like you have difficulty chewing some certain textures of food. Then you, after swallowing also, you have a feeling that something's stuck in your throat. So these are the common symptoms that are seen in individuals diagnosed with MS. The first step for any swallowing related difficulty is to visit your speech language pathologist. These are some things that you can't really manage at home without expert help. So you have to get a swallowing evaluation done. Maybe sometimes we can also use the help of instrumental evaluation like FEES or video fluoroscopic examination. These come at the later stage, but first visit your SLP, and so that they can understand at which phase of swallowing you're having a difficulty. And accordingly, swallowing exercises, maneuvers will be taught to the patients. Till you visit your SLP, there are some safe swallow strategies that you can follow at home. Avoid drinking directly from a bottle. It's always better for thin liquids like tea, coffee, or water, juice, that you pour it in a cup or a glass and you drink slowly. Take small quantities at a time. Make sure you finish what is already in your mouth before taking another bite. Diet modifications for those who have difficulty chewing, so you can go from instead of a normal diet, you can go for a soft diet or semi-solid diet sometimes. So according to the individual and their impairment, you will modify the diet. And also avoid distractions during meal times. Avoid talking while eating. These are some things that you can follow at home, and the rest of it, definitely your speech language pathologist will help you. So I've come to the end of my presentation. Thank you for listening. And this is just to remind you that multiple sclerosis presents differently in every patient. Every patient is different. So the symptoms that one patient might be experiencing, the other patient might not. That is why it is very important to come and get your assessment done first, and then the treatment goals are decided based on your impairment. Thank you. So the next speaker is Ms. Ipshita. She is an occupational therapist, and she will take you through the role of an occupational therapist in managing MS.
Thank you, Sneha. So I will be
just one thing, for the convenience of all, we have kept English as the common language for our webinar today. In case later anyone has any questions in Hindi or Bengali, we will definitely take it up and resolve it, and we'll deal it accordingly, but we'll continue in English as a standard medium of language. Thank you so much.
Good morning, everybody. I will be talking about role of occupational therapy in case of multiple sclerosis. As we all know, multiple sclerosis is a chronic progressive demyelinating disease. It affects the activities of daily living. Occupational therapists, we are concerned about your activities of daily living. What is activities of daily living? It is a regular routine task like as simple as eating, drinking, taking bath, getting dressed, going out, driving, going for work, or meal preparation. This all comes under activities of daily living. Because of all these symptoms associated with multiple sclerosis, our activities of daily living gets affected. So as an occupational therapist, we do not aim at altering the course. As we all know, this is a progressive disease. So we aim at maximizing the potential of the client to minimize the disease impact and to have some changes in the lifestyle. So in case of impaired sensation, as an occupational therapist, I'll suggest you to regularly check the skin because bed sore might get developed. The vulnerable areas are under the ear, under the head, your shoulder, your elbow, your buttocks, heel. So we need to check regularly. Is there any changes in the skin color, or is there any changes in the softness or hardness of the skin? So we need to check for pressure sore also, and also for any cut or wound, because the sensation is not there. Whenever you are handling any extreme temperature like hot and cold equipments or any sharp object, we need to be very careful during that. The suppleness of the skin has also been mentioned, maintained by putting some moisturizer. In case of diplopia means you will have double vision. In case of such visual problem, you can use eye patch or a frosted lens in the spectacle. In case of poor vision, we can use this color coding system for different equipments and container with larger levels, or we can use magnified lens. The basic activities of daily living usually gets affected. In such case, like if you are having problem with bathing, usually what happens, the person gets so much tired while taking bath. So what we can do, we can take bath in a seated position. So in the bathroom, we can use a stool. We can use this hand rails near the hand basin. Non-skid mats can be used in the bathroom to prevent fall. Raised toilet seat can be used so that it will be easier for the person to stand up and sit down. It will reduce your energy expenditure, and also the fear of fall will be prevented. Grab rails can be used in the bathroom. In case of dressing, it gets usually affected because the dexterity gets affected. What is dexterity? We cannot do the fine things very in a fast way. We cannot put the button, or we cannot use the zip. In such cases, this button hooks are used, or we can modify the garments, like loose fitting garments can be used. We can change the buttons and zip into we can attach Velcro so that it will be easier to don and doff the clothes. Dressing stick can be used. This is a dressing stick which is used to position and pull up the low garments. Reachers can be used. If you want to reach for anything, you can use the reacher so that the energy expenditure also, again, it will be reduced. We can use elastic shoe laces or slip-on shoes so that bowing thing we do not have to do. Grooming is something like the female need to put the makeup, or the male need to do shaving and all. Anything we do to keep our hygiene will come under grooming. So if you are having this problem, like incoordination is happening while doing those activities, then what we can do, we can use weight cuff. We can use weight cuff and do all the activities, or any electrical thing equipments can be used, like electrical toothbrush or electrical shave. instead of the manual one. While eating also, there is a fear of food spillage. Because of incoordination, the food might get spilled or it might fall over us. So in such cases, scoop dish, this is something known as scoop dish, which prevents the spillage of the food. Rocker knife can be used. This is a T-shaped knife, which do not use this sawing motion. The rocking motion will be used. This is very easier to control. The cut injury is less in a case of such knife. Plate guard can be used. If the plate is moving because of the your incoordination, then plate guard can be used, or as simple as a damp dish towel can be used to prevent motion of the plate. This is something known as plate guard and plate holder. Swivel spoon can be used. This spoon, like however you move the spoon, the food will be there on the spoon. The technology is like that. So this can be used in case of incoordination. Even this particular method can also be used, like while eating, you can stabilize your elbow and the arm over the tabletop and have the food with a wet cup, so that you can have your food easily without involuntary movement. If there is a fear of this fall of spillage of liquid over the body, then straw can be used. This is a straw holder glasses with handle. The common problem all of the multiple sclerosis patients suffer with is fatigue. We feel so tired while doing all the activities. So as an occupational therapist, we can suggest you some strategies. We will evaluate your routine, which activity is making you so tired. In such cases, we will suggest with energy conservation and walk simplification, which will help you to get less tired. The strategies you have to follow, and you can do all the activities without getting much tired. Temperature control also affect your fatigue level. So it's better to use some cooling jacket, use of fan, cooler or AC as appropriate for you. You can avoid sunbathing and doing exercises outdoor, so that it helps to control your body temperature and eventually your fatigue level. We plan activities for you to manage your incoordination, to manage your dexterity, to maintain your hand strength. We can also help you with your work. Like if you're having any difficulty with your work life, then we can help you by assessing the work you are doing, what problem you are facing. So we can help you with training related to your work, or we can just suggest you to modify the environment, the work environment. We can also help you with driving. If you are having problem with driving, we can assess you and suggest some training or any reasonable accommodation in the van or car. These are all driving rehabilitation we can help you with. Thank you. Now I will invite Mr. Prabhat Bose, our rehabilitation psychologist and vocational counselor. Please, sir.
Good morning, my dear participants. As my colleague Ms. Ipsita has introduced me, that I am a psychologist, clinical psychologist, rehab clinical psychologist. But what I say to all my patients is that আমি হচ্ছি মনের মানুষ, মন কি ব্যক্তি, because in our society, in our country, we have lot of stigma related to visiting a psychologist or a psychiatrist. So if you make a psychologist your friend, you will be more comfortable to share your difficulties with them. Okay, so start with the main goal of psychological rehabilitation is to improve and preserve the mental and physical abilities of the patients, mostly who are affected with the MS, and also help patients to adapt with the changes, because the persons who come across or get onset with the MS, they have to go through lot of changes in their life. Okay, let's move on to the role of a psychologist, like what I do to all my, like if you come to a psychologist or if you come to me, how can I help you, or how a psychologist can help patients affected with the MS. By starting with, a psychologist can provide lot of informations related to the MS, which a person's or layman may not be knowing, related to the different directions of the MS difficulties. Like, you all need to know the technicalities of the MS, because until and unless you don't understand what MS is, you won't be able to manage it. So for that, you need lot of informations and support. And psychologists can also help you to adapt and learn to cope with their new realities. A psychologist can also help you to develop strategies to cope with the physical, mental, and emotional and social changes. And the ultimate goal of a psychologist is to empower the persons who is affected with multiple sclerosis. Now, there are few psychological concerns, and being a MS patient, you should be aware of this. And the major psychological concern is that almost all the patients who was affected with the MS go through a particular phases of life. It's called 5 stages of grief, that is commonly known as DABDA. DABDA stands for denial, D stands for denial, then anger, then bargaining, then depressions, and then acceptance. It's like once we get into a chronic disease like MS, these are the 5 stages that every person or many of the persons can go through. Like, first, they deny the fact that they are affected with something related to MS. Then slowly, after a few times, they start agitating. And then the third stage is bargaining. Like, they start bargaining with the God Almighty that why me in this world got affected with this. Then there comes depressions. Once they understand it, they start getting into depression phase. And the last stage is acceptance. Like, after going through all the phases, they start accepting the new fact. So this is the stage where they need, or almost all the patients need, is expert support, psychological support. And as we know that MS is a very complex severe disease. So in that case, not only the patient suffers, along with the patients, the family member, the parents, the spouse, they also go through a lot of changes. And the commonly psychological disorders that almost all the patients get affected are anxiety, sadness, depressions. These are the diseases or disorders that almost all the patients can affected in some part of their life. Okay, so the psychological support. Now, there are 2 types of support that a patient can get from a psychologist. First is called psychological support, because they can affected with the following difficulties, like perceived stress. They can have lot of stress, uncertainty regarding their life. They can find difficulties in coping and to make strategies how to deal with their life. Lack of social support, because they can disconnected with the entire society, and there can be thinking errors. So for all these things, you need psychological supports. The second difficulties that a MS patients can get is that cognitive approaches. Like, they may find difficulties in thinking, processing informations, in attention, executive functions. Executive functions is understand and follow instructions. Like, if some instruction is given to a persons, that persons may find difficulties in understanding that, and after understanding, to perform accordingly. that is called executive functions. Then remembering, like memory. A patient with MS can also have memory difficulties. So for all these difficulties, you also need a psychological support, like cognitive approaches you need. Management, how you can manage your MS. In managing MS, the first and foremost support that you need is your family and spouses. They provide you the emotional stability and support during the health complications. Then, okay, once you get onset with the MS, you can have two different types of approaches. The first approach, there are people who can get involved with the emotional challenges. They do not able to come out of the emotional challenges, and there are some other people who can find managing themselves cope with the new situations or their new reality. So you need to understand that how will you engage yourself, like seeing only the difficulties, like, okay, I have this difficulty, I have that difficulty, or instead of looking into your difficulties, you should look for approaches that how you can handle those difficulties. Then you need a expert support, that is called CBT. CBT is a type of therapy that a professional provides. So CBT can help you to manage your thoughts and your behavior. Then the next is mindfulness. It is another type of therapy that also helps you lower down your stress level, your anxiety level, and mood disorders if you have so. Okay, then the next approach or management is that every person who is affected with MS should get themselves engaged with different social services. Like you should look for your peers who also who have the same sort of difficulties, and you can reach out to help them. And the last is that you also can get engaged in sports, social work, or recreational activities, because these things will also help you managing MS. Okay, now another thing is that comes under this management is that rehabilitations, like vocational rehabilitations. Like if you were engaged in some sort of occupations and after onset of MS, you are unable to manage your existing work, like the occupations. So in that case, you can also look for vocational counselor or career counseling. So in INK, we also provide that, or a psychologist can also help you in that career counseling or vocational rehab. Now, I want to let you know regarding the Disability Act. Like if you have MS, or every MS patient can also eligible or go for disability certificates. Now there are certain ways how you can obtain that certificate. First, there is an act called the Rights of Persons with Disability Act 2016. It's a central government act. So under this act, MS is mentioned, like person who has affected with the chronic neurological disease like MS. So you are eligible. You can also go to the government agencies to collect your disability certificate, and after the obtaining of the disability certificate, you are eligible for different central government benefits. So to conclude with that, I would like to know that MS, if you look into that the amount of physical difficulties we assume that MS can cause, in reality it can cause much wider than that, because once a person is affected with MS, her entire psychological, mental, social, everything get affected. And it's not only affecting the person's physical difficulties, but it also affect the every component of a person's health. Thank you. Now I would like to request Mr. Somesh Mondol. He is our prosthetist and orthotist expert.
Thank you, Prabhat sir. Good morning, everybody. just I am going to discuss use of orthosis and assistive device in multiple sclerosis. My name is Samesh Kumar Mandal. I have done
A
bachelor in
little louder,
prosthetic.
please. You're very soft. We can't hear you.
My topic is use of orthosis and assistive device in multiple sclerosis. My name is Samesh Kumar Mandal, bachelor in prosthetist and orthotist. I have done my bachelor from National Institute for Locomotor Disability, Kolkata. First of all, I just introduce what is orthosis because this is less familiar profession. So my orthosis is an external medical device which supports the weakened part of the body, and assistive device is designed and adapted to assist person to perform particular work. Second thing is how many kinds of types of orthosis. There is 3 types of orthosis: upper limb orthosis, trunk orthosis, and lower limb orthosis. Actually, we are doing dealing with the locomotion difficulties in the MS. So it is very important for the standing and stabilize the weakened part of the our body. So there is some objective why orthosis required for the MS: to prevent deformity, stabilize spine, prevent pressure sores, stand and ambulate the patients, and return to the society as a useful and happy productive life. This is lower limb orthosis. First one is when foot is not slapping on the ground or unstabilized, the ankle joint cannot raise the foot, then we provide one orthosis, supporting device, that is called ankle foot orthosis, which helps to ambulate the patient and maintain the energy conservation. And second is also ankle foot orthosis. This is bilateral one. And third one is knee brace. This is when patient are standing or walking, knee getting buckled. So for the support of knee, we use knee brace. And third one is very severe cases when knee are very weak, then we give to them metallic knee brace. These appliances should be very lightweight so that energy should not be consumed more. This is the upper limb orthosis. Splinting job we are doing. Sometimes when finger is not very weak, cannot hold the thing, then we make splints for the finger. The first one is thumb spica. Maintain the wave space of the finger to hold something. The second one is elbow brace. When patients are getting flex or contracture or cannot raise the hand, then we use elbow brace to strengthen the elbow. Third one is cock-up spleen. When wrist getting down, cannot raise the wrist, then we provide support to the wrist, that is called cock-up splint. Some in the lower bottom end, we are providing dynamic splint to strengthen the finger. Just the small girl are doing exercise with the dynamic splint. Sometimes neck becomes weak, cannot hold the neck in the position, so provide soft collar for the support in the neck. Sometimes patients are getting low back pain and prolapsed intervertebral disc. In that case, we are providing a lumbosacral belt that is one made from cloth. Second one is molded, and third one is metallic. You also use assistive device. Suggest to use assistive device for the patient with MS. First one is canes. Third one is the axilla, second axilla crutch and elbow crutch, and walkers, so that he can ambulate in the inside the room or mobile locomotion from one place to other place. On the extreme cases, when patient are not get stand or locomotion, in that case, we suggest them to use light wheelchair with some modification like cushion, which prevent to make pressure sore in the buttock. And sometimes we are making modification so that if ulcer is there, so ulcer cannot for the relief of the ulcer, to cut that places. So the ulcer should not be touched in the area. And this is the air cushion. So over the wheelchair, we are modification so that patient getting ulcer-free life. Thank you. Now I'm calling Dr. Vidisha, other physiotherapist, to give his profession for physiotherapy. Thank you.
Thank you, sir. A very good morning to one and all present here. Myself, Vidisha Adarsh, I will be proceeding with the physiotherapy management in multiple sclerosis. So more often we come across with the patients complaining, ma'am, we are not able to move our limbs properly. There is breathing problem. There is, again, breathing difficulty. All the limbs are weak. We have balance issues. We have fatigue. We have coordination issues. So everything comes at a time. So for that, we need to evaluate the patients accordingly, and for that, we need to make a proper phase. Now, the phase it involves evaluation by identifying and quantifying the effects of disablement. Then comes the treatment, therapeutic exercises, task requisition, and environmental modification. Now, what do we mean by this? Now we know what are the problems we are facing, the patients are facing. Therapeutic exercises, we make a proper plan, how often we have to give the exercises, what are the repetitions we have to give to the patients so that they will not go for fatigue. Task requisition, and ultimately what is our goal? The patient should go back to their environmental habitat, like in society, in home, how they are going to proceed. So based on that, we need to form our own goals and intervention accordingly to the disease course. Is it acute, subacute, or chronic phase? Coming to the acute phase, what do we focus mainly on? Pulmonary advancement, avoid pressure sores by positioning. Now, pulmonary advancement, under this, deep breathing exercise is one part. Apart from this, what do we focus on? We focus on the bronchial hygiene. For bronchial hygiene, we go for deep breathing exercises. If there is if there is maximum secretion, that also need to be secreted out. Now there is coughing technique, there is huffing technique, depending on the condition, whatever the patient is facing. So for deep breathing exercises, what can we proceed with? We have to ask the patient to inhale for 4 counts, hold for 7 counts, and then exhale for 8 counts. Repeat this for 5 to 7 settings. Then comes early mobilization. Now, this is called as tilt table. I understand tilt tables are not available readily, maybe available, but when we go for readiness, it is not that available. But then in case if you have it, please use it. It is very helpful in improvising the cardiovascular tolerance towards postural change. And what do we mean about this? Our patient, they they be in the bed for most of their time because they cannot move their limb. So in case if they're not able to move their limb, what will they do? They'll be lying. So for that, postural change is very important. Weight bearing over the joints prevents orthostatic hypertension so that they will not feel giddiness once they're going for sitting or standing. Okay, next up, we get a question, okay, ma'am, we don't have tilt table at home or at our place. What do we do then? Then comes other assistive devices. Other assistive devices such as long knee brace, using walker with full support. We can give support sideways so that the patient will be standing with support, of course. Okay, by early mobilization, it is not just making the patient vertical or making the patient stand or go for moving and all. We can make the patient sit at the edge of the bed. That also comes under early mobilization. Okay, next up we have subacute to chronic phase. In this phase, we mostly go for strengthening, stretching, positioning, everything. Strengthening exercises, we start from passive range of motion, active assisted, from active assisted to active to resisted movement. Now, what is the difference? The difference is passive movement will, under passive movement, the therapist will be doing all the movements for the patient. Your patient is not able to do any movement at all. Active assisted may, once the patient has obtained a minimal amount of muscle power, they will be assisting. They will be doing the movement. We are just assisting. Active is once the patient is able to do on their own, everything they will be doing. Then we go for strengthening using weight cuffs, pulleys, TheraBand, other things for resisted exercises. Okay, I'm going to briefly just talk about this. This is a protocol that we follow: aerobic, flexibility, as well as resistance training. Now, aerobic training, how much is too much? This question also we get very often. Like, when do we know that we need to stop right there? That is a question. Where do we need to stop? For that, first we need to assess how much your patient can take. Every patient is different. There's a patient, he can just take 5 kgs. I will not be giving them 10 kgs of weight cuff and then ask them to do 10 repetition maximum movements. So for that, we need to check the repetition maximum, 1 repetition maximum. Based on that, aerobic exercises, 30 minutes per day, excuse me. Based on that, aerobic exercises 30 minutes per day is enough. 3 to 5 sessions per week. That's it. Then we go for resistance training. Resistance training preferably to be done on non-aerobic exercises day. Like I've done aerobics on Monday. Tuesday, I'll be going for resistance training. Not on the same day. Again, to avoid fatigue. So resistance training, again. Ma'am, how many repetitions should we do this? 8 to 10 exercises maximum involving your major upper limb, lower limb. Then work on balance and coordination, 8 to 15 repetitions and with 1 minute of rest. Then comes our flexibility training, in which we go for all stretching exercises, active movements, whatever gives you more flexibility, active movements, passive movements, everything. Then stretching exercises for all the muscles that are going for tightening. Yes, due to prolonged bedridden patients, what happens? Most of the muscle, they'll go for tightness. So for that, we need to stretch those muscles. Pelvic rotation exercises, it gives us balance while walking or while standing. Then comes coordination exercises. Now, under coordination exercises, Frankel exercises are very good pattern. In Frankel's exercises, most of us, we know how to explain it. We just ask the patient to sit or stand, whatever is comfortable for the patient. Make a semicircle line, draw the numbers, 1, 2, whatever, how many ever the patient can do, and ask the patient to touch the numbers with right or left leg, arbitrary, not in a uniform manner. Next up is walking on the foot run. Again, this helps very well in the coordination problem. So in footprints, what happens? With just 1 foot apart, we make foot patterns and ask the patient to put the foot exactly on the point. For Frankel's exercises, the principle itself says concentration of attention, precision, and repetitions. As there is a saying, practice makes a man perfect. Coordination exercises with repetition, it gives very good results. Then coming for ataxia, there are many balancing exercises that helps. For example, tandem standing, narrow base of stance, alternate leg and arm raise. So with narrow base of stance or tandem stance, what are we doing? We are just reducing the base of stance, which helps in balancing the body. Now, aquatic exercises. In aquatic exercises, if the patient already knows, he or she has already learned the swimming process or other things, then it is fine. Otherwise, we do not go for like new sessions of aquatic exercises because it might cause fatigue. Apart from those, yes, hydrotherapy helps a lot. Next is virtual rehabilitation. Virtual rehabilitation is a machine where we give virtual scenario, and then we ask the patient to follow the steps. Whatever is shown in the TV or in the screen, they have to follow it and do as it is, as the screen is saying. So along with this, with one arm, with two arm, with one leg, with both the legs, they can easily do the balancing exercises. Next up is very important, urinary incontinence. Now, urinary incontinence we come across in women as well as in men. So there are steps to follow in urinary incontinence where we ask the patient to do the following things. They have to tighten and lift the anus, squeeze and lift the vagina, tighten to stop the flow, combine all 3 steps, relax and rest. Now this also they are supposed to do for 8 to 10 sittings, 3 to 4 times a day. Okay, and in case if we get a man for urinary incontinence, it just differs as we ask them to squeeze and lift the urethra inside and upward. Hold for 5 to 10 seconds and then relax. Next up is vestibular rehabilitation, in which there are multiple exercises that we give to the patient, like looking for right side, left side, without moving the neck, just with the eyeballs. Next is focusing on a target, moving neck right to left without moving the eyeball. Then shoulder shrugging, forward bending of the neck, extension of the neck, sit to stand, like sitting on a chair, then getting up, again sitting down, 8 to 10 repetitions again. Then coming to the advanced stage. Now we have already trained the patient for muscle power, relaxation, then stretching, balance, coordination, everything we have taught the patient. Now, what is the ultimate thing we want to do? We want our patient to walk. So consider our patient are not still in a position where they can walk without support. So what do? We go for assistive devices. So in this case, we can see what I have used. We have given long knee brace to the patient along with, this is called as reciprocal walker. So in this gait pattern, yes, we are giving support to the patient, but why we are giving again knee brace, all the supporting system, so that his knee will not be affected. He is also wearing AFO, ankle foot orthosis, again helping the foot so that slapping will not be there. So along with these kind of training, we can mobilize our patient. Once they are done, once we are thorough with this, the patient is able to walk very independently. Then we ask the patient to go for all the society process, like wherever he is working, environmental places, wherever he wants to go. That is the main goal. So for that, we are training the patient. Thank you. Next up, I'd like to call our director, sir, Dr. Shuparna Ganguly, to proceed further.
Thank you, Vidisha and the team. I think, as I promised initially, that we won't go into the theoretical aspect of MS and just focus on the practical scenarios. That is what we have done. And thank you for those presentations. Now, what I'll just try to do, I'll just try to sum up the whole thing. So, what actually is needed, and the most important part, is assessment. So physical assessment, you have a functional assessment, speech, swallowing, psychological, which includes both cognitive as well as behavioral assessments, nursing assessment, dietary assessments, because these are very important part of in treating a patient. And at the end of the day, we as doctors, we try to set a plan, a rehab goal for a particular patient. So it is basically a patient-centered, goal-oriented rehabilitation approach. It's of no use using a blanket strategy for everyone. We need to tailor make each person's problems, and we have to address them accordingly. So in terms of neuro rehabilitation, whatever we have explained, I am sure you might have got a gist of it. Now, usually the scenarios for neuro rehabilitation is either in the outpatient department, or we also have an outreach team who takes care of patients at home. We started our tele-rehabilitation services, so that is also in the treatment process. And there are a few patients who will benefit from a short stint of inpatient rehabilitation. So what one message I would definitely try to share across to our friends: do not brush your problems under the carpet. If you have problems, acknowledge them, share with your relatives, and definitely try to get in touch with an expert wherever he or she is, but try to get in touch with an expert. One more advice for the caregivers, one very important advice: take time off, because the whole brunt is on you. You need to arrange for some home care at home when you are taking time off from the from your dear one's care. If you face problems in terms of need for a psychological counseling, seek help, because it's of no use being ashamed of your psychological problems, because the more you brush it under the carpet, the worse it is going to get, and it will become difficult for you as well as us to help you. So at the end, it is basically not one patient, it becomes two patients. So this is very important and imperative to understand that once a patient is diagnosed with multiple sclerosis, that is not the end. That is just the beginning. And taking everything into account, we have to accept, we have to learn to accept and move on, move forward. Remember one thing: neuro rehabilitation team is of utmost importance in taking care of a patient's holistic needs. at INK Neuro Rehab, we are always with you and Amra apnar sathe achi. Now, before we wrap up the session, there will be definitely a question answer session. We already have a few questions, and I'll just run through those questions so that it will become easier for everyone to answer them, and it will definitely help you all as well. Now, after the question answer session, I'll just take 5 minutes for you all to be shared with a film which we just made on a patient and the caregiver. So it won't be of too long. It will be only a 5-minute movie. So I'll just run through the questions quickly. And there was a question from one of our friends. There was a lecture in 2024 which mentioned as hard exercises.
I too have a question.
Sure, I'll definitely take your question. Let me just finish this and I'll get back to you. So hard exercise may precipitate MS attack. Now, how to determine the threshold so that a person with multiple sclerosis won't cross the limit and is safe while continuing with physiotherapy? I think Vidisha mentioned that during her presentation, but I would just like you to enlighten on that.
Hello, am I on?
And this question was from Guwahati.
Yeah, so for that, first we need to assess how much our patient will be able to take it. First, we check for 1 RM. What is 1 RM? How much repetition maximum a patient can do for 1 repetition? Maximum weight he can take. Based on that, we make a proper protocol which he can follow. It depends upon patient to patient. As I said, I cannot give 10 kgs to a person who can take 5 kgs. So based on that, I will be making my own protocol, what my patient will be able to do based on the capability, according to the assessment I have done for the patient. With that, with repetition, safe value is always 8 to 15 repetitions. Twice a day, we say, and with rest. Without rest, again, the patient will be going for fatigue and further problems. So rest for at least 1 minute is always prescribed.
Thank you, Vidisha. The next question is also from Guwahati, I guess. Is it safe to do hard mental exercises like computer programming? I mean, is there any likelihood of MS precipitation after doing hard mental exercises like computer programming, deep thinking, etc.? If so, simply put it as how much is too much? So I think, yeah, Prabhat, yeah, I know.
Like there is a saying, excess of anything is not good. So, and we all aware that we should not get too much of screen sharing time. But yeah, if you can practice as much is needed for you, for your memory purpose, for focusing your attention. Yes. So like 30 minutes per day or 1 hour per day, split into 30 minutes twice a day is
true. I think like if I just answer this question in a nutshell, it will be.
Hello, sir. Balaji.
Sorry.
I am Balaji.
So, are you asking a question or just commenting on it, ma'am?
No,
Balaji.
I'm
Okay.
just want
Oh,
to
sorry,
know.
sir. Okay, just give me 1 second. I'll just answer this question and I'll come back to you. So,
Okay,
in
sir.
terms of how much is too much, I think for a patient who has been diagnosed with MS, it is always good to have a break time in between activities. Now, every patient is not same. As I mentioned, we have to tailor make the rehab program accordingly. Even the functional activities, the functional tasks, the activities of daily living need to be spaced out. So it is very important to space out your daily tasks, be it computer programming, be it dressing, be it eating, be it anything. And you have to avoid fatigue. That is probably the basis of any rehab program, any daily activities for a patient diagnosed with MS. Now, sir, do you want to ask a question or shall I continue with the other questions?
I have a question, sir.
Yes, please.
Hello.
Yes,
Yeah,
please.
this is
Please,
Orko.
please.
Yeah, this is Orko Sina speaking. I want to know for an assistive device that you have described here. One assistive device for gait training is functional electrical stimulation. Is that available in Calcutta or is there a help in INK? Because that is a great help to MS patient as we see. FES, but I am not getting any help in Calcutta city. How do I get through it if I want to?
Hello. Yeah,
Yes.
we have FES available at our institute. We use it for
Okay.
both physiotherapy as well as occupational therapy for whatever the condition comes. We have electrical
Right.
stimulator, we have functional electrical stimulator, both as well.
Okay. So I can visit your place and have a help from you people, right?
Absolutely, absolutely. You can come and visit us.
Okay. So the
Okay. Thank you, ma'am.
I'll just, yeah, thank you. I'll just move on to the next question. Now, again, this is how to build up resilience against MS. Any training, mental conditioning, etc. are there, Prabhat?
Yes. Yes, I have mentioned that in my slides that you should get engaged with different social services, get into social work activities, get into recreational activities. These are the things that can build resilience against MS, like different sort of activities.
Again, at the end of the day, your day has to be spaced out. That is very important. It's just not what you are doing physically. You need to, if I say, distract yourself from just one work. Just focus on your any sort of like if you're interested in gardening, if you're interested in whatever sort of things which will keep you engaged. I think that is some, because resilience doesn't come just over a day or overnight. It takes time, and until and unless you have that mental strength, until and unless you have accepted your problem and move on, you are still not resilient.
So I want to add,
Yes.
yeah, as you said, that your days should be spaced out and structured.
Structured. Very important. Thank you, Prabhat. Acha. Now, the next question is in terms of Mediclaim. Physical and occupational therapists are very expensive. So please don't be. Need some assistance in enforcing insurance to cover costs for therapies too. Now, there is a range mentioned here, 700 to 1200. But we are much less than that. INK Neuro Rehab department is much less than the amount which has been quoted here. Anyway, is there any Mediclaim for hospitalization? Yeah, I think I can answer this question. Now, each insurance company has their own way of helping patients. Now, in our institute, I can definitely say that there are a number of schemes, be it government insurance coverage or even private insurance coverage, which takes care of the neuro rehab program when you are admitted in the hospital. So that is something which has been answered. Now, one thing which is very important here, main reason for many to quit job is cognition. So I think Prabhat has already mentioned that in his presentation. What I can add to it is, if people again under the psychological banner, it is as cognition and behavioral. Cognition is definitely a challenging problem for people with MS, and it might be subtle. It might be a blown out cognition problem, or it can be an invisible subtle problem. Now again, it boils down to one thing: you need to be assessed. If you are facing any problems in terms of your physical or psychological, please contact an expert, because it's always good to pick up things early rather than be sorry late. Okay. Please.
I have a question. Right now, there is a lot of heat wave going on across India, especially in Calcutta. It's very extremely hot. So what do you recommend for exercise? Like during that time, not everybody has air conditioning at home and other facilities. So what do you recommend? Do you recommend doing exercises during that time, or just, let it be during that time?
So the exercise regime will be absolutely optimal. You are not supposed to overdo anything, because again, it is heat. It will drain out your energy. It will cause dehydration. There will be problem. The patient will not be able to take that much. So it will be optimal. Yes, they can do general exercises. I will not go to resistive and aerobics, but general exercises, yes, they can do, just to maintain the muscle property, joint properties, and the mobility of the body. That's it. Not much.
Yeah. I think just to add on to that, during this heat or summer time, what needs to be done is maintenance therapy. So whatever you have learned, you know it, and if you are practicing it, if you have been practicing it over a period of time, you know what and how your body will react to it. So it is more of a maintenance therapy than actually getting into strengthening stuff. Okay, I think just to extrapolate your question, there is one more question here. For hydrotherapy, will the heat and humidity immediately after the session and in the changing room be an issue?
Again, for hydrotherapy, the optimal temperature is 33 to 36 degree of the water. So it will be 2 or 3 plus minus in the changing room. So it will not cause much problem for changing, and you're not going to stay in the changing room for the whole day. It will be like 5 to 10 minutes for whatsoever. So it will not cause any problem as such.
I asked this specifically because there was a case where people went through an exercise therapy session, and actually the symptoms aggravated after that. So the thing is when to stop.
That's what it should be optimal. It, as Sir said, it will be maintenance therapy when it is too much heat.
I think one more
Yes, sir.
thing which the patient also needs to understand, that where he is finding difficulty in continuing the exercises, because sometimes it happens you're in the middle of the exercises and your adrenaline rush is there, so you just think in your mind 5 more minutes and I'll be over with the schedule. That is where you end up in a problem. You should know when to stop. Last question. One thing is to add is, patient with MS often have a complaint of nystagmus and double vision. That is also to be taken care of. Now, yeah, I think the visual rehab, I think Ipshita should be able to answer on
In
that.
such cases, as I said, we will be using this eye patch, or frosted lens can be used in alternate eyes for alternate days. Eye patch can be used, or frosted lens and spectacles can be used.
So for this, what we need is basically visual rehabilitation, and at INK, the occupational therapists, they do the visual rehabilitation part quite. It's manned by expert professionals. So I think we have come to the end of the question answer session. If Anirban can just allow. Sorry.
Sir, excuse me. This is Maheshwari Natsimhan from Chennai chapter.
Hello.
I want to ask 2 questions very quickly, and 2 things I want to share here, very important things. Okay, as you said, your whole program today was in nutshell, but very effective and very, very informative. It was very well designed. Really, it was good. It was really in nutshell. And here I want to say, my question is, what is the expansion of DABDA? There's something I learned which is very new. Denial.
So I can So if you so I can explain quickly what is DABDA. So it is a D is for denial. So it's just not for MS patient. It's for any sort of problem. So whenever we face up, like for example, for a loss in the family, you have lost your mother, you have lost your whoever, and the first reaction is, I am in a denial phase. No, I haven't lost my dear ones. Next is the anger phase. Why me? It could have happened to anyone else. Then it is the B phase, which is bargaining. You bargain with God. God, please treat my MS. I'll do this for you. I'll get a diamond jewelry for you. Something like that. And then comes the depression. When you understand that things are not working even with bargaining, then you start getting depressed. You feel your mood is off. Over a period of time, when everything else has failed, you accept. That is what I always keep on mentioning. Accept, learn to accept as early as possible, so that you can move on and you can move forward with a happy, healthy life.
Okay, now thank you so much for the explanation. The next thing is your rehab assessment. What you have. I think my chairperson, Mrs. Ann Golsarve, is on this link right now. And I would request her to invite you people for this assessment campaign. Definitely, we all need to go through the assessment, because by just saying somebody is not able to walk or not able to talk is not MS. It could be anything. An assessment should be done properly.
Thank you for reiterating that, ma'am. Thank you.
Okay, and my question here today, you said that, like, this is for all of us who are on this link now. You said that don't push anything under the carpet. I have gone through in last March, I've gone through a difficult phase where whatever food I intook, it just remained up to the gullet. It was not moving down. So I thought it is a symptom of MS and I ignored it. Then when I went to my neurologist, he put me onto a gastro doctor, who then did an assessment of doing an endoscopy, and it was found out to be an infection, HPE, something called calorie, which no one knows what exactly it is, but this is where the esophagus gets infected and you're not able to push the food beyond a given level. The food remains in the gullet and it often comes out also. This is not part of MS, but we just ignore it, saying that it's something to do with MS, and we ignore it. This is one thing we all should understand here.
Yeah, absolutely.
So this is a sharing book.
Sure. So it's so good that you all share your experiences. So I think that is what the webinar is all about. Like, it's a sharing platform so that we know what you all are facing, and you also know that you need a proper neuro rehab team anywhere. It's not just INK, anywhere, but you need that support, and they are always there for you. Thank you, ma'am, for that question. So there's one more last question from Hyderabad. So this is for Sneha. Thank you for the wonderful session. Today I got to know the symptom terms, one of which I am suffering right now, anomia. So difficult to find the words and how to manage with that problem. Sneha.
Okay, so word finding difficulty is commonly seen in MS. So there are a lot of exercises that you can do with your speech therapist when you come for the session. I'll talk about some things that you can do at home. So every day, I think you should practice naming the things in the home which you use, things like your comb and toothbrush and things like that. Personally relevant items, not just like animals or any random thing, but personally relevant, because that is what we should know first. So I talked about queuing hierarchy also. So when you're finding a difficulty recalling a name for a particular object, and you're practicing at home with your spouse or other family members, So how can your spouse cue you? The first step is not giving the answer to you, but the first step is describing the object to you. So this is what we use it for. This is what it looks like. The second, after that also, if you're not able to recall, then the second step would be providing you with the first letter of that object. So for example, if they're asking you, showing you the phone and asking you what is this, they can tell that it starts with the letter P, or it starts with the sound F. So that way they can cue you. And these cueing strategies, you can also do it for yourself. That is what we call self cueing. So this will also help you recall the name of the particular object.
Thank you, Sneha. So I think we have come to the end of question and answer session. If you have any questions for nursing staff or for dietitian, you can do that because we have our departmental head of dietary and nursing staff also here. So if there are any questions, you can quickly write to us. In the meantime, I'll just show you a film which we usually make every year. This is our second of that, and just have a look at it. It's about a patient and a caregiver. Just 5 minutes.
আরেকটা দিন আমার 24 ঘন্টা কাটাতে হবে। এই বেশি দৌড়ে দৌড়ে নেচে নেচে যাস না। রায় রায় আমি একটা দুম করে একটা আওয়াজ পেয়েছি, ঠিক মানে একটা যেমন ভারী জিনিস পড়ে যাওয়ার শব্দ। প্রথমে নিয়ে যাওয়া হলো বাঁকুড়া হসপিটালে। মিশনে আসার পরে ওরা সিটি স্ক্যান করেছে, 15 দিন থাকলো ওখানে। ওরা ইনিশিয়াল সিজার্স এর কিছু ওষুধ দিয়ে দিল। আই ওয়াজ ডেসপারেট। আমি জানতাম যে হয়তো কিছু একটা এসপার ওসপার হয়েই যাবে, বাট স্টিল। হ্যাঁ বলুন।
আমি পুরো ঘটনাটা শুনলাম। তোমরা এক্ষুনি আইএন খেতে নিয়ে যাচ্ছ না কেন?
কলকাতায়?
হ্যাঁ,
I had no other options.
Please.
স্যার আমি রায়ের মা।
প্লিজ বসুন।
স্যার এখন আমাদের কি করণীয়? রায়ের কি হবে?
দেখুন, সবথেকে যেটা ইম্পর্টেন্ট অ্যাসপেক্ট সেটা হচ্ছে রায়ের যে একটা সিভিয়ার হেড ইনজুরি হয়েছিল সেটা থেকে এখনো বেরিয়ে আসছে, কিন্তু এখন ওর যেটা মেন প্রয়োজন সেটা হচ্ছে নিউরো রিহ্যাবিলিটেশন, যেটার থ্রু দিয়ে উই উইল ট্রাই টু গেট হিয়ার ব্যাক টু অ্যাজ নর্মাল অ্যাজ পসিবল। 3টে ওয়ার্ড, কিন্তু এর পেছনে একটা বড় টিম এফর্টের প্রয়োজন হয়। ব্রেন ইনজুরি পেশেন্টস, পার্টিকুলারলি যারা বাচ্চা, তাদের আউটকাম উইথ কোমা স্টিমুলেশন প্রোগ্রাম বেশ ভালো। এবার এই টিমে ফিজিওথেরাপিস্ট, অকুপেশনাল থেরাপিস্ট, স্পিচ ল্যাঙ্গুয়েজ প্যাথোলজিস্ট, রিহ্যাবিলিটেশন সাইকোলজিস্ট, নার্সিং স্টাফ এবং আমরা এই টিমটাকে লিড করি অ্যাজ ডক্টরস। আমি এটুকু আপনাকে এশিওর করতে পারি যে ওভার আ পিরিয়ড অফ টাইম রাই উইল ইমপ্রুভ।
রাই আবার আগের মতন হাঁটতে পারবে?
এইটুকু আমরা প্রমিস করতে পারি যে ইন দ্য নেক্সট 3 to 6 উইকস রাই নিশ্চয়ই হাত ধরে হেঁটে বাড়ি যেতে পারবে।
হ্যালো, হ্যাঁ সে কি? হ্যাঁ করুন নিশ্চয়ই, ঠিক আছে। মনের একটা চোরা কুঠুরিতে যেটা জিনিসটা বন্ধ হয়ে যায় না, সেই জিনিসটা, সেই দরজাটা খোলা যায়। হ্যালো
হ্যালো হ্যালো, যাবে না?
আমি কোনোদিনও ভাবিনি এই অবস্থার মধ্যে দিয়ে যেতে হবে। আমিও ছোটবেলায় বাবাকে হারিয়েছি। তোমাকে দেখেই আমি শিখেছি কিভাবে এগিয়ে যেতে হয়। মনের জোরের উৎস তুমি। আমি পারবো। রায়ের জন্য আমাকে পারতেই হবে। যেভাবে একটা নিউবর্ন বেবিকে সবকিছু নতুন করে শেখাতে হয়, ওকে সেই রকম সবকিছু নতুন করে আবার শেখাতে হচ্ছে। যেমন হাঁটা, তারপরে খাওয়া। ও তখন নড়বড় নড়বড় করে হাঁটছে, ওকে ধরে ধরে হাঁটাতে হচ্ছে। ব্যালেন্সটা তখন একদমই নেই।
মা, স্কুল যাব না?
যাবি তো? লড়াই আছে, রাইয়েরই লড়াই আছে।
So again, at the end of the day, it's accept and move on. Thank you. I'll just request Anirban to wrap up the session, please. Thank you. Please, Anirban.
Yes, sure. Oh, well, good afternoon to all. Thanks for being with us for so long from the morning. Actually, the film makes us think of so many things, and even the symptoms, what we have been through, we have gone through, we have fought for so many years, were so well described and practically demonstrated by Dr. Suparno Gangopadhyay and the entire team over here in Institute of Neurosciences, Kolkata, INK. I think it is because of the wonderful guidance and leadership of the founder chairman of INK, Dr. R.P. Sengupta, who's based in the UK, but he often comes here and we keep on interacting. And he has always tried to help us. And all the doctors out here, Dr. Suparno, Dr. Ashish Datto, Dr. Rishikesh Kumar, as mentioned here, and the technical, the medical staff here, they have been always so helpful. The admin people here, Joita, Moushaki, I mean, I don't know whom to thank, who all to thank rather. And you know, MS is with so many invisible symptoms, as we were just now talking. So the fight has to go on, and we have to get over so many obstacles. And it affects people at the prime of their age. So that dabda thing, of course, denial, and then you have to accept and move on, and we have to fight. And some points which came out, we have a tendency to put all the blames on MS. See, we are a normal human person and we are all aging. So our body will have some other problem also. But we can't blame everything on MS. But yeah, it happens. It's very normal. But I think this session today, I can only say it's been well attended from all our friends all across the country, all our chapters, they have participated, and I hope it has given some positive inputs to all of them and their issues. And this is just the beginning. As we have spoken, Dr. Shuparno Gangopadhyay and ourselves, we have planned. This is just the beginning. Going forward, we can always have more sessions like this at INK with the team of INK. And the motto or the issue which we want to handle is make our lives slightly better than before. Whichever way we can be helped out, we will be together as a team, we'll fight on and we'll survive and enjoy our lives. I think nothing more to say, especially the film we just saw. That's how life is, and life has to go on. I wish you all the best. Have a lovely day. And yes, it's very hot and humid out here. So please keep yourselves hydrated. Take care of yourselves. All the best. We'll be in touch always. Thank you so much.
Dada, can I say something?
Yeah, sure.
See, with the INK support, probably you can split up the program, like one day for memory and the related issues. One day related
May I know who's this, please? I'm sorry. May I know?
Maheshwari
Okay,
Narasimhan from
fine.
Chennai chapter.
Fine, understood. Please carry on. Yeah, ma'am.
Yeah. So taking the liberty, I can talk to you because I know
Please.
you very well.
Yeah, of course.
I think you should split up the topics and we should have a good discussion with INK because the presentation is very good, the understanding is very good, and we should take it forward.
Thank you so much. In neuro, they are one of the best in this part of the country. If not, we have a lot of.
I think we should rope them in. We should not let them go.
No, they are very much with us. That's why we are here. But yeah, as I said, their chairman, founder chairman, Dr. Sen Gupta, has always been our huge supporter. And of course, the entire team, the doctors, the other medical, non-medical staff also, they are always supporting us very well.
Everyone. Very supportive.
Yeah. It's a team effort. Yeah. Thank you so much, Maheshwari.
Yeah.
Okay, so let's close the day. Thank you so much for joining. Thank you very much. Thank you.
Goodbye, all. Goodbye.
Bye.